Hello, so my name is Tina Habchi, and I'll be presenting today COVID-19, the scientific truth beyond conspiracy theories. So we're going to start off with an introduction following the origin of the virus, the risk factors, as well as symptoms, before getting into the epidemiology, of course, and how the virus is transmitted, following the mechanism of action and how the immune system responds to the virus, and then ending it with diagnosis, prevention, and treatment before concluding. So, COVID-19 is an infectious disease caused by a new coronavirus introduced to humans for the first time, as this new strain hadn't been identified in humans before. So, we're currently facing a pandemic with the virus spreading so easily and the situation evolving so rapidly. It is still under ongoing investigation, but to start off, it is crucial to have a name. So, the World Health Organization announced on February 11, 2020, its official new name, Coronavirus Disease 2019, abbreviated as COVID-19. So in COVID-19, CO stands for corona, V for virus, D for disease, and 19 for the year 2019. So as for the origin of the virus, December 2019 marked the first cases of COVID-19, and through research, it was shown that this new coronavirus with a single-stranded positive RNA genome was genetically similar to SARS-CoV and MERS-CoV, belonging to the genus Beta coronavirus and to the family Coronaviridae. So with further investigation, the coronavirus was traced back to a local seafood market in Wuhan City, Hubei province in China, where wild animals and live poultry were being sold and where this virus could have been originated. So looking at this picture of the live animal market, we have a vendor here who is preparing a frog for sale in the street with unwashed buckets, the dirty scale on the side, the frog being slaughtered for the client, other remains of fish and frog with the rest of the live frogs for sale. So the genome sequence was identified and was compared with the bat coronavirus, here named RAT-G13. So according to the Genome Organization, the genome consists of 6 open reading frames, ORFs, listed as ORF 1A, 1B, 3A, 6, 7A, 7B, and 8. Along with these ORFs are other accessory proteins such as S, E, M, and N proteins. The genome of this coronavirus shares similar organization with the other known coronaviruses. And when comparing the genomes of the coronaviruses, it is shown that the new coronavirus has great similarities with especially the bat coronavirus, RAT-G13. As we can see here on the table, the nucleotide sequences and amino acid sequences are almost identical for each domain, and with an overall genome sequence identity of 96%. So the close identical relationship of the 2019 coronavirus with RAT-G13, the bat virus, may be the right evidence to suggest that it may have originated from bats. Now, another study, however, may suggest another possible source of origin. Instead of the whole genome, when investigating specifically the S protein more into depth, and the S protein is the protein at the surface of the virus that allows its entry into the host cell. And looking specifically at the S1 domain here in green, which is the receptor binding protein, it has been shown that the genome sequence of the new coronavirus is more similar to the one of the mammalian pangolin. So in fact, looking at this figure 2, while the pangolin coronavirus shares all 5 boxed major amino acids with the 2019 coronavirus, the RAT-G13 only shares the first one. So this shows that the pangolin coronavirus is more similar than the bat coronavirus in the S1 domain specifically, though initially the overall genome sequence did show that the 2019 coronavirus seemed to be more identical to the bat coronavirus. So in this case, this may suggest a possible recombination event that may have occurred between the bat coronavirus and the pangolin coronavirus, indicating a much more complex origin. Now, looking at the risk factors, coronavirus can infect and cause serious symptoms to anyone, which is why everyone is currently taking the same precautions to prevent the virus from transmitting. However, it is certain that some people are more at risk than others, and the increasing number of reported cases show that people at higher risks include the elderly and people with health conditions, especially hypertension, cardiovascular disease, diabetes, chronic respiratory disease, and cancer. Several cases were reported with pets being infected by their human owners, including a German Shepherd, a Pomeranian, and a domestic cat. So these pets have shown low-level infections of the virus after being tested, proving that they could have picked it by their already infected owners. So also a Malayan tiger was tested positive at the Bronx Zoo in New York after showing symptoms and is believed to have been infected by an employee as well. So not only is the risk of animals being infected low, but there are also no cases of humans getting sick from their pets, meaning that they do not have a role in transmission. And finally, it is important to consider that endangered great apes could possibly be at risk since they are our closest relatives. So though there are still no confirmed cases, it is still important to take precautions since they have shown to be susceptible to other human respiratory diseases that can cause them to become even more sick than humans and even die. Now, it appears that symptoms are showing up in people within 14 days of exposure to the virus, and this is called the incubation period for COVID-19. In other words, infected patients are first asymptomatic, meaning that they do not display any symptoms despite having the virus in their systems. It is only after this incubation period of 14 days that signs and symptoms of the infection appear, and some people may think that they've only caught a cold or flu due to the similarities in symptoms. So the symptoms of COVID-19 include fever, cough, and shortness of breath. Tiredness may also be experienced, as well as aches, pains, runny nose, nasal congestion, sore throat, and diarrhea. So the symptoms range from mild to severe. And while many cases are mild, there are more severe cases with more serious symptoms, such as pneumonia, bronchitis, multiple organ failure, and even death. So these severe cases occurring in people with high risks are recommended to immediately consult their health provider for medical attention. Now, as for the epidemiology, since the whole world is declaring a state of medical emergency in the face of the drastic rise in cases, representing exact numbers is almost impossible, as they are constantly changing. Data is being collected based on reports from health authorities worldwide, and as of May 11, 2020, we have around 4 million reported cases that have been confirmed, with 278,000 deaths, according to WHO. So these numbers are increasing drastically since the growth rate is exponential. And the numbers of confirmed reported cases and death are collected by country, territory, or area, and by the date of report. So the data is best represented in graphs to further study the epidemic curve. So to bring the pandemic to an end, each country has to flatten the curve. In other words, to achieve a plateau. So three major examples are shown here. We have the United States of America, Italy, and China. So with the pandemic, while it is very close to an end in China, as the graph represents the curve bend, it is only getting started in some countries such as the United States, who haven't taken the right precautions initially. While Italy had also hit the media for how severe the situation had gotten, the curve is currently slowly regressing. And here we have Lebanon as well, who is, for now at least, considered as one of the winning countries. So at this point, it is crucial to follow strategic objectives to flatten the curve and to end the pandemic. Now, based on the origin and how it has been transmitting, it is clear that the virus is zoonotic, meaning that it is transferred between animals and humans. It is also community spread, meaning that it is spread with the source of infection being unknown. So many are getting infected within an area without surely knowing how, when, or where exactly they got infected. This is because of the incubation period in which people looking healthy may be infected and spreading the virus. In fact, a study shows that it is pre-symptomatic transmission of about 1 to 3 days before the symptoms appear. So the coronavirus is spread through close personal contact by touching or handshaking, through the air by coughing and sneezing, allowing the infected person's droplets of saliva to travel to others, or through the touching of a surface or an object with the virus deposited, and then directly touching your face and allowing the virus to get through before washing your hands. Now, figuring out the structure of the new coronavirus first would allow scientists to understand its mechanism of action. So here, using transmission electron microscopy, researchers were able to view an isolated virus and show its spherical shape as well as the spikes around its surface. Hence, the given name of the virus, coronavirus, since the external structure of the spikes on the virus looks like a crown, with corona in Latin meaning crown. So looking closely at the proteins at the surface, the specific major type of protein that allows the invasion of the virus into human cells is found to be a spike protein or S protein. As we can see here in figure 4, researchers have shown that these proteins bind specifically to a receptor on respiratory cells called angiotensin converting enzyme 2, so ACE2. Now, looking closely at this figure to explain the mechanism of action, just like every other virus, the coronavirus binds into a receptor here, ACE2 entry receptor, and attaches to it. Before, of course, penetrating, the virus enters the cell body through the ACE2 entry receptor and is engulfed by the cell before it then uncoats and releases its RNA to then enter the nucleus where it uses the host cell to create new virus RNA. And of course, the new viral RNA particles are then assembled and packaged before being released to proceed and continue making new virus. So after discussing the virus's mechanism of action to invade human host cells, it is crucial to understand how the immune system responds to the virus intervening the human body. So it turns out it starts by activating its innate response to fight the virus by releasing interferons, which are proteins that suppress the replication of the virus and activate human cells to fight it. They also signal the neighboring cells to take precautions of a possible encounter with the virus. This innate immune response is actually responsible for the appearing symptoms that signals the body of an attack by a fever and to expel the virus by cough or diarrhea. So the initial innate response tries to contain the virus for the first few hours before the adaptive response takes lead with the activation of T cells and B cells. So B cells secrete antibodies that recognize the spike proteins of the virus to destroy it and can provide more lasting immunity that protects the body in case of reinfection by memory. So unfortunately, since this virus replicates so quickly, it is difficult for the immune system to respond and control it as efficiently as it normally would with other viruses. So a suppressed immune system is also another factor to consider for vulnerable elderly with already pre-existing medical conditions for having a slower and weaker immune system. So having slower or weaker immune systems would delay the defense response further and cause even more damage. So in this case, the immune system may exaggerate by releasing more cytokines, which are inflammatory proteins that not only target the virus, but could also affect the host cells. So this uncontrollable response of the immune system is what is called a cytokine storm. So looking here at this figure, in the first column, we have an uninfected individual with healthy pulmonary epithelium and normal circulation and no symptoms. Looking though at the two other columns, moderate COVID-19 and severe COVID-19, in the moderate case, we have damaged epithelial cells with the increase in levels of cytokine and the common moderate symptoms of fever, cough, and fatigue and myalgia as well. While looking though at the severe case, we have more damaged epithelial cells and much higher levels of cytokine, leading to the cytokine storm, which we're referring to. And more severe symptoms, of course, such as fever, cough, fatigue, myalgia, dyspnea, respiratory failure, and ARDS. Now, the plasma cytokine levels were assessed to examine the presence of cytokine storm in 9 severe cases and 7 moderate cases. So it has been shown that levels of interleukin 2, interleukin 6, interleukin 10, and tumor necrosis factor alpha, TNF alpha, were found higher in moderate cases and increased in severe cases, while interleukin 1 beta, on the other hand, was undetectable almost. So the proportions of immune cells were also then examined, and results show low proportions of T cell subsets in moderate cases and further reduction in severe cases, while B cells were not reduced in most patients, but severe cases show an increase. So this suggests that cytokine storms might be associated with disease severity. This proves that the patient's death could be caused not by the virus itself, but by the cytokine storm, with the accumulation of protein-rich fluid in the lungs, as seen here in the first figure. More severe symptoms appear, such as the blocking of gas exchange and the collapsing of the alveoli. So this causes acute respiratory distress syndrome, ARDS, which explains all the needed ventilators in hospitals. The virus could itself spread to the rest of the body and invade cells of other vital organs, since it has been shown that other organs, such as the stomach and the intestines, for example, also have the ACE2 receptor at their surfaces. Also, the protein-rich fluid may travel through the bloodstream, causing inflammation of the patient's other vital organs and leading to systemic inflammatory response syndrome, which may further lead to septic shock and multi-organ failure. In fact, some patients have reported to have kidney, intestinal, and heart inflammations. This shows that the response of the immune system can be counterproductive, even leading to death. So at this point, it is important to distinguish what the real killer is. Now, looking closely at the renin-angiotensin system, here we have angiotensinogen that converts into angiotensin 1 by renin, that then converts into angiotensin 2 by ACE. So normally, angiotensin 2 would convert into angiotensin 1,7 by ACE2, but of course, with the coronavirus that binds into ACE2, we postulate that the coronavirus attenuates the ACE2 activity via internalization, skewing the balance to a state of predominated by high levels of angiotensin 2. And the high levels of angiotensin 2 would instead bind to the angiotensin 2 receptor 1, AT1 here, and would instead cause pulmonary vasoconstriction and inflammatory, ultimately progressing towards ARDS. And it has been shown, in fact, in this graph, that the plasma concentration of angiotensin 2 in coronavirus infected patients were significantly higher than in healthy individuals. Furthermore, increased plasma levels of angiotensin 2 will increase aldosterone production by adrenal glands, and leading to high blood pressure and platelet clotting. Now, the effect of aldosterone on the structure of platelet fibrin clots in the blood plasma obtained from rats treated acutely with vehicle and aldosterone were seen here. We can see the relative clot density evaluated using a confocal microscope that shows a significant increase in the aldosterone group compared to the vehicle-treated group. And moreover, the aldosterone effect was comparable in both platelet-rich plasma, PRP, and platelet-poor plasma, PPP. So thus, aldosterone altered the structure of platelet fibrin clots and resulted in thrombosis. Now, looking at the diagnosis, real-time RT-PCR testing is a diagnostic method that can detect even the smallest amounts of viral genetic material in a sample, since it is duplicated many times over through the process of amplification and makes it more reliable with results appearing after a few hours. Now, firstly, a test sample is swabbed using a skinny swab long enough to reach the nasopharynx before it is processed to isolate the viral genetic material. Only the RNA is extracted, purified, and reverse transcribed to DNA. Then small pieces of primers are introduced and and complementarily bind to the target sections to initiate the process of amplification. Putting the sample in a RT-PCR machine allows repeating cycles of copies. Finally, fluorescence is used as markers to bound to these copies, and the results are viewed in real time on the screen. So positive results show fluorescent markers with viral genetic material, while negative results don't. Although RT-PCR is the reference standard, a recent study was conducted on patients who were reported as potential cases to evaluate the efficiency of RT-PCR compared with another diagnostic method, here the chest CT. So a chest CT scan is a type of X-ray that is much more detailed, showing different images of the lungs and inside the chest. As we can see here in the figure, we have the chest CT of a 29-year-old man with fever for 6 days. So initially, his RT-PCR test was shown to be negative, though looking at his chest CT scans, we see in the first column normal chest. Before then, as we can see in the yellow arrows, we have first minimal ground glass opacities before they then increased in column C. So this shows, in fact, that chest CT scans are actually more sensitive in detecting the coronavirus at an early stage, and that both chest CT and RT-PCR should be used complementarily for better efficiencies. It was the same case for many other patients, as we can see in the second figure, where most initial RT-PCR tests were negative, while initial chest CTs were positive. Now, while RT-PCR tests may take hours before getting results, it is crucial to figure out another way to get them instantly. So fortunately, at a time like this, with the ongoing pandemic, the coronavirus rapid test kit is a rapid serology test for in vitro diagnostic use. It detects IgM and IgG antibodies in human serum, whole blood, and finger pricks that are produced in response to the presence of the coronavirus. So the collected blood is diluted and added into the detection cassette. And here we have two tests that run side by side. We have on the left the negative test and on the right the positive. So in both cases, we have a control line that indicates the quality control, as well as red blood cells that migrate across the device. Now, as for the positive test, we have an extra band that indicates that antibodies have been produced in response to the COVID-19 infection. However, of 49 individuals, 22 tested positive by RT-PCR. In contrast, the rapid test detected only 11 of those positive correctly. So given the low sensitivity, it is recommended not to rely on an antibody-based rapid test. And as a discussion, the weak detection could be due to the fact that antibodies require more than 14 days to develop in high concentrations. Thus, using PCR would be sensitive to minute traces of coronavirus. Now, there was no control in preventing the spread of COVID-19 worldwide. However, couldn't this outbreak have been prevented if it was first predicted? Now, unfortunately, a study was done in 2007 on the emergence of severe acute respiratory syndrome, SARS, in which scientists have warned the world on a possible reemergence of a coronavirus outbreak that could have been avoided if only our world leaders had listened to scientists and had taken the right precautions. In fact, the study explains how coronaviruses are well known to undergo genetic recombination, which could create new genotypes and therefore new outbreaks. Even in 2015, Bill Gates predicted that there would be a next pandemic, just like this current coronavirus pandemic, in his TED Talk. He warned that an infectious virus may be the next threat to humanity, that the world was not prepared to handle a new outbreak, and that this should be of our main concerns to be prepared by investing in global healthcare systems. At this point, though, since it is already too late, it is crucial to protect ourselves. Now, coronavirus is spread from one person to another, mainly by the infected person's droplets from either coughing, sneezing, or even speaking. This is why it is suggested that a distance of at least 6 feet is kept between people. Crowded places should be avoided and people should stay at home, social distancing themselves from others and practicing self-isolation. Since the virus can survive on surfaces, it is important to keep the surfaces that we touch clean, including doorknobs, light switches, handles, tables, toilets, phones, and the list goes on. To disinfect these dirty surfaces, most common disinfectants would do the work, such as bleach solutions and alcohol solutions containing at least 70% alcohol. Regularly washing hands with an alcohol-based hand gel containing at least 60% ethanol or soap and water for at least 20 seconds before touching your face is recommended. Covering your mouth and nose with your elbow or tissue that is then disposed while coughing or sneezing is also recommended. It is advised to wear a face mask for the sake of others not to get infected. And of course, keep yourself up to date with the latest news for certified sources. Now, as for the treatment, as many people thought that the virus could be treated like any other virus, scientists beg to differ. And while it is very easy to get prescribed with antibiotics, unfortunately, since antibiotics do not work against viruses, but only against bacteria, they shouldn't be used in order to prevent or treat coronavirus. Now, to seriously discuss some of the potential treatments, the bright side is that most people with mild symptoms can recover on their own. As of now, there is no specific treatment to follow for this disease, so it is only required to relieve the appearing symptoms. In more severe cases, some research drugs may be used as options to try to target the virus, but their effectiveness are still under clinical trial. Though assumptions were made about chloroquine and hydroxychloroquine, two drugs used for the treatment of malaria that have been in the headlines as effective treatments in blocking the entry of the virus, scientists have lost enthusiasm for these potential treatments as they have shown life-threatening side effects. Patients were shown to be at risk of abnormal heart rhythms that would lead to sudden death. It is suggested to be used for patients who do not have pre-existing medical conditions, though they are the ones that are most in need of a treatment, and who should be connected to heart monitors just in case. As many trials have shown that there is no clear evidence of chloroquine and hydroxychloroquine to be beneficial, and it seems to have more poisoning effects instead. Now, though vaccine development has always been the answer to all the viral diseases we have lived through in the past decades, there is still no vaccine for this new coronavirus. And unfortunately, developing a new vaccine may take longer than we ought. It may take from a few months to even a few years before discovering a promising vaccine. But in the meantime, until a vaccine is discovered, it is important to consider other treatments. With that thought, instead of a vaccine that will get the active immunity to respond, we can consider instead getting the passive immunity to respond. In other words, instead of getting the immune system to respond to the antigen by synthesizing its own antibodies, we can immediately provide the patients with already synthesized antibodies from recovered patients. This treatment is convalescent plasma collected from survivors of COVID-19 that are antibody rich. So although this passive antibody therapy is still under clinical trial, it has been newly authorized by the FDA for emergency use, but there are high hopes for this treatment to be beneficial for the next few months until the availability of a vaccine. Experience from previous outbreaks has shown quite positive feedback from the use of convalescent sera, and it can be used either for prophylaxis, meaning that it is administered to people at higher risks in order to prevent infection in the first place, or by therapy to treat already infected patients. Instead of using the sera of COVID-19 survivors, would it be effective to use the sera of SARS survivors? As we've seen, SARS and COVID-19 do have quite similarities. Convalescent SARS patients exhibit a neutralizing antibody response directed against the viral S protein. Scientists investigated whether such antibodies block the new coronavirus-driven entry. So in this figure, we have 4 sera obtained from 3 convalescent SARS patients inhibited SARS-S, but not VSVG-driven entry in a concentration-dependent manner. These sera reduced SARS-2S, which is the new coronavirus, driven entry, although with lower efficiency compared to SARS-S. Similarly, rabbit sera also reduced both SARS-S and SARS-2S driven entry with high efficiency, with again inhibition of SARS-S driven entry being more efficient. Thus, antibody responses raised against SARS-S might offer some level of protection against SARS-CoV-2 infection. Also, mesenchymal stem cells, MSCs, have emerged as a potentially attractive candidate for the management of ARDS through facilitating lung tissue regeneration and repair due to their low immunogenicity, their pleiotropic effects, and their preferential migration to the site of damage. MSCs were initially obtained from bone marrow before then being isolated from various other sources, such as the umbilical cord blood, amniotic fluid, placenta, dental pulp, liver, lung, thymus, and so on. So as for the mechanism of action, we can see here in this figure that MSCs secrete paracrine factors that can increase alveolar fluid clearance, regulate epithelial and endothelial permeability, facilitate endothelial repair, and anti-inflammation. MSCs can also secrete extracellular vesicles that activate cell-to-cell communication, cellular signal transduction, cellular metabolism, and immune modulation. And finally, we can see that MSCs can also donate their own mitochondria to the host cells to restitute alveolar bioenergetics and enhance the phagocytic activity of macrophage. So as for the clinical trials, we can see here in the graphs, the profile of serum cytokines before and after MSC's treatment in severe patients. So we can see that interleukin-10, which is anti-inflammatory, increases after treatment, while TNF-alpha, which is pro-inflammatory, decreases. And this shows the efficiency of MSC's treatment. Now, to conclude, COVID-19 is an infectious disease caused by the newly discovered zoonotic coronavirus, said to have originated from the pangolin in Wuhan, China, but it actually explained by such a complex origin. It is so easily transmitted that it has caused today's pandemic. We have seen how it has activated the innate immune response with type 1 interferon response, pro-inflammatory cytokines, and the cytokine storm. Adaptive immune response with the activation of T lymphocytes and B cell response, and of course the renin-angiotensin system with the increase in ACE-angiotensin 2, increase of aldosterone, and vasoconstriction, causing much severe symptoms such as hyperinflammation, lung injury, coagulation, thrombosis, and multi-organ damage. Now, we are still working closely to respond to this situation by the early diagnosis of the virus and the seek of potential treatments. In the meantime, it is crucial to prevent the spread of the virus by spreading awareness, to take precautions, and to follow the right measurements. Leaving us with many open questions, let's further brainstorm during the discussion. But with everything being said throughout this presentation, facing all the conspiracy theories, whether the virus is man-made in China, transmitted through 5G, or even owned by Bill Gates, I hope that I shed the light on the scientific truth of COVID-19 and that you see it beyond all the conspiracy theories. Thank you and stay safe.
Now we are open to handle your questions, and we would like to ask Dr. Zaraket as well to intervene and to help us answer the questions. Fine. Go ahead, please. Who has questions? Feel free as well to type your question on the IM platform.
I have a couple of questions.
Yes, Julian, please go ahead.
Okay, so why does COVID-19 have a long incubation period with respect to other flu viruses?
This is actually a good question. We don't really know why it is slower than flu. Now, definitely, it's as Tina said, there are different families. It could be that the virus takes time to take over, really, in terms of the amount of cells infected before we, trigger the symptoms. But why it takes 2 weeks, it's not very clear. For some other viruses that usually take longer incubation period, they have a different path. They go to the respiratory tract, then to the lymph nodes, and we have primary and secondary viremia, and this is when they start showing their symptoms. But for COVID-19, it's really a straightforward path. It's just right where it wants
to be. It's local, directly leading to the inflammatory at the local of infection, at the site of infection.
Yeah, so it lands in the respiratory tract, and this is where the initial symptoms appear. Now, definitely, we have to acknowledge that not all people develop symptoms so late. the majority of people develop, or on average, develop symptoms around day 5, which is not much longer than the flu, for instance.
Yes, true.
But some patients do remain asymptomatic for more than a week.
Fine. Thank you. Thank you, Julian, for the question. Other questions?
I still have more, please.
Yes, go ahead.
Okay, can COVID-19 still affect the body if it was transmitted through saliva instead of inhalation?
I meant first also to commend Tina really on this nice overview. I didn't have a chance to comment.
Thank you so much.
With respect to the saliva, I think Julian was referring to the chance of oral transmission. And if so far there's no evidence that COVID-19 can transmit via the oral route. Okay, definitely if saliva is dispersed into droplets and then these are breathed in, then yes, it can be transmitted for sure by saliva. But if this is consumed, like ingested, then so far we don't think this is the case. But whether it happens or not, even in a small proportion, we cannot be definite.
Despite the fact that we do have ACE2 on intestinal epithelial cells?
Yes. Now, mind that the virus would have to go through the digestive system, and then it has to resist the acidity of the stomach before it reaches the intestine. There were some evidence that there seems to be local replication in the intestine, and this is evident by the fact that there is substantial detection of viral RNA and subgenomic viral RNA in the stools. So when we have the subgenomic RNA in the stools, it means that there's potential replication going on in the intestine. But how the virus makes its route to the small intestine, we're not sure. There are studies that shown that we can detect the viral RNA in the blood, but I haven't seen any study that showed actually infectious viral particles in the blood, which could explain that the virus is transmitted via circulation to other organs, including the intestine.
Interesting. Thank you so much, Dr. Zaraket. Fine, we move forward with other questions. Thank you, Julien. Our external audience.
Yes,
we have read your question. Yes, go ahead, please.
Yes, so I'm just wondering actually about the paradoxical link between the ACE2 receptor, so the receptor responsible for the entry of the virus, and the hypertension patients. Because for some patients suffering from hypertension, we know that ACE2 is actually the cause, and they could be treated by treatment against ACE2 actually. Nevertheless, they still suffer, or they do not suffer, but they're still actually infected by the virus and actually having bad symptoms. So why do we have this? Maybe not for Tina basically, but I don't know if Dr. Zaraket, we have actually this kind of answer.
Dr. Zaraket, please, we need your help again.
Sure.
Thank you.
So it's right. There were two sides to this argument or to this discussion. One, whether people on ACE2 inhibitors and on the angiotensin receptor blockers are more protected from the disease, COVID-19. And knowing that people taking these drugs have increased expression of ACE2, some other scientists were concerned that this actually predisposed them to more risk of infection. Now, the binding target of the COVID-19 and ACE inhibitors, while it sounds the same, it's different. So the spike protein binds to a different target than these inhibitors. Recent studies, there were several nice studies published in New England Journal of Medicine, showed that patients who were actually receiving ACE2 inhibitors or ARBs, angiotensin receptor blockers, were rather showed beneficial benefit in infected patients. And this is mostly not because they're protecting them from COVID-19, but they're probably improving the cardiovascular outcomes in these patients. Okay, so the benefit is indirect. So to answer your question in a nutshell, we don't think that these medications are protective against the virus, but probably they can protect from the severe outcomes.
Thank you. Thank you
Okay,
so
thank you.
much. Thank you, Yara. Sola is raising a question whether we can develop twice COVID-19. So in other words, if we're infected and we don't develop, or whether we do develop an adaptive immune response, are we still prone to develop a secondary infection? Tina, do you have an answer for this?
The exposure to the coronavirus the first time will activate B cells to create basically antibodies as memory. So the induced immunity for this coronavirus means that the human body will most probably maintain that memory of the virus for at least
but then
years.
we don't know how long, right?
Yeah, we don't know how long. But at least
Dr. Aad was discussing this.
That yes.
Yeah, Dr. Zaraket, do you have anything to add on this, please?
No, I agree. Now, historically, we know that the immunity to coronavirus, especially the SARS, is not long-lived. So maybe a couple of years, a little bit more. But in the short run, I really don't expect that we should see a lot of reinfections. This virus has been surprising us in many aspects, but I hope it doesn't surprise us in this aspect. And at least we haven't seen a lot of reports of reinfections that more like they were false positives or really due to the fluctuation of viral titer in these patients. So they appear negative for a couple of times and then positive again. So I don't think there's any evidence.
Otherwise, we'll be locked down for a couple of years.
Well, Esther, we are going to be here for quite a long time now.
Well, 3 days ago, Dr. Zaraket was commenting on this, and he said he doesn't expect before 1 year.
Yeah, 1 year, 1 year and a half. These are the lowest estimates. But I actually had a comment slash answer to the question of immunity. The problem with that is that there is no research so far, and Dr. Zaraket, correct me if I'm wrong, that has actually been able to pinpoint how long does the antibody last, one. Two, whether the immunity that we develop once we have contracted COVID-19 actually lasts for the next COVID-19 season, since we don't have a second season yet. So there is still a lot that is unknown with this virus, just like you said. So even the antibody test and the fact that it's not very reliable to this point actually indicates that the load of antibody that is present in a certain person after they've contracted COVID-19 or while they've contracted COVID-19 is very variable and cannot be very reliable in testing for antibodies. So yes, they are using the convalescent plasma right now, but even with that, they haven't published any data as of yet that actually says how effective it is or how promising it is and stuff like that.
So this goes back,
All we hear is hearsay at this point.
Yeah, true.
That's
it goes back with what,
that we have right now.
what was mentioned. Thank you, Paula. Thank you for your valuable input. Now I'm going through the questions from the external audience. We have Carol Abu Hamdan with us. Hello, Carol. Thank you for the question. Is it true that coronavirus can infect intestinal cells and multiply inside them? I hope Dr. Zaraket has already mentioned this and you got the answer. And is it true that the coronavirus causes blood clotting? Tina mentioned something about aldosterone level and blood clotting. So hope we answered your concerns. Nadim Burji, is Nadim with us? Nadim, he's posing a question whether corona is human-made. And I think we have to go through this in a while, the conspiracy theories. Rhea Zarqa, the mechanism by which COVID-19 attacks the lung cell and its subsequent result. Tina has covered this early during her talk, so I hope it was well explained and clear to you. Sami Karam, how is coronavirus not a living being and yet has a DNA? Tina, can you comment please on this question? How come coronavirus is a non-living and yet has a stretch of genetic material?
This leads back to like defining what living is biologically. Though the virus is the thing about the virus is that it is an assembly of molecules, of nucleic acids, of proteins, though it does not live alone. It could not be independent, and since it depends on host cells, in that case, we consider it as non-living.
Yeah, true. But it has its own genetic makeup to survive.
Yeah, it carries like an assembly of. So.
Thank you, Tina. Now we go back to other questions. Any other questions on the list?
Yes, I have a question.
Yes.
So would the increase in the temperature reduce the infectious rate of COVID-19?
Excellent question. So whether I don't have the answer, I guess Tina as well. So we will revert to Dr. Zaraket. Please, Dr. Zaraket, could you assist in this question?
Yeah, sure. At least in the lab, we know that the viruses usually have optimal temperatures in which they grow in the cell. So, for example, human viruses grow optimally at 37 degrees. Avian viruses grow more optimally at slightly lower temperatures. So this is one of the defense mechanisms of the body, is to increase the temperature. But remember now, the virus is an override, and it can really overcome this barrier. And I would expect that the temperature is not really uniform within the respiratory tract. So it's one of the defense mechanisms, just like the immune response, that's not always successful in really halting the replication of the virus.
Fine. Thank you, Dr. Zaraket. Other questions? So, Dr. Zaraket, we would like to hear about the second wave that we are expecting. So, would it be more severe, or would it last for a longer period? Could you please give us your opinion about this?
Yeah, sure. There are many factors that control the second wave. In the first wave, we usually know where to expect the virus coming from, so it's easier to take measures to control its spread. And given that the virus is still not really widely spread in the community, then once you do the closure of the country, then you control it. And this is what we've seen in the first wave in Lebanon. Whereas in the second wave, this will depend on the factors following. First, will the weather really affect the transmissibility of the virus? If the temperatures are warming up and then humidity is increasing, potentially, yes, that would reduce the transmission, but not to the extent of really stopping it. The other factor is really the behavior of the community. So the more there is contact within the community, the faster this virus can transmit, because the transmission chains are more connected. The less the connection in the community, you'd expect that these transmission chains would be smaller and more confined. So the third factor is depending on how fast the Ministry of Health teams can really track the cases and their contacts and isolate them, and then how much these contacts would follow the directions to stay home and self-quarantine themselves. So if any of these factors go wrong, we could lose control on the second wave. So we know that there's going to be a second and probably a third wave, but the scale of this wave can be variable. We're not sure about this current wave, how much it will grow.
Okay, thank you so much. But we're talking here about the same strain, so not another strain with another mutation, right? Since the period is quite short.
Yeah, so far we haven't, there's no evidence really that any of the mutations have really helped the virus transmit more or less. Now, this could happen in whether it's in the second wave or in the third wave. Some properties of the virus might change, but so far we don't see any major differences or changes that are actually affecting transmission of the virus.
Okay.
So I used the acronym last time. It's like either we go on like a hilly road, just one small hill after another, and this will be the journey for the coming year or more, or we just take a steep mountain road that they've seen in some countries like Italy and the United States. So hopefully we'll be on a hilly road, not on a mountainous road
hopefully.
with this outbreak.
True. Lamar here she's raising few concerns or question. She's mainly concerned about the radiation, the 5G radiation, and its effect on the origin or on the evolution of COVID-19. And what's the reason behind the fatality rate in certain races that is higher, especially in a Black race? And are there certain races are more affected? So is it DNA related? So if we can split the question into two parts, the first one, the effect of 5G radiation, because we heard a lot of conspiracy theories and fake, mobile fake, but a lot of social media news that was spread quite easily, exponentially even, among in the public and among non-scientists. So what is the relation between 5G radiation and the origin of COVID-19? Is there any correlation?
Is this for me or Tina?
Tina, let's just give a chance to Tina. Tina, do you have a say on this?
I think that since 5G is at such a low frequency, I don't know honestly if it would explain the quick transmission of the virus to the body.
It's non-ionizing, right? It's non-ionizing, so we don't expect it like UV or X-ray to cause mutation at the genetic level, right?
Exactly.
So Dr. Zaraket, do you agree with Tina's?
Yeah, I mean, I learned something that I didn't read a lot about 5G by its own, that it's not ionizing. But for sure, there's no scientific evidence that these radiations or signals can affect the virus transmissibility. Now, people always find something to associate with, but we've seen these pandemics happen historically, time over time. And, there wasn't 5G before. There was something else probably. So I don't see any reason to associate this with 5G. It's really natural that we see these outbreaks, and scientists have for a long time warned about potential outbreaks, let it be from whether it's Ebola or influenza. Scientists working actually on coronaviruses have warned that some of those present in nature have the potential to really infect human cells. But it's like searching for a needle in a stash of hay, and sometimes it's difficult to really get the response or get serious response from the leading people.
We need more scientific.
So I think this is one pandemic, and we'll have more pandemics.
She might be tammin with more pandemics.
Oh, yeah, I mean, disease X, it's called disease X. It can be anything. You fill in the blank.
Okay. So here we have another question from Elisa. We will answer two more questions since we're running out of time. Is there an expectation for the period of time that's going to take this pandemic to end? Is it likely that a vaccine will develop? We already come across all these, or that people will either die or develop immunity. Elisa, I'll try separately to discuss your concern. The second part of Lamar's question was about the races and whether certain races are more prone to infection. So is it related to any ethnicity? Do you have anything to add on this, please, Dr. Zaraket?
We're still at the beginning of the outbreak, so there might be some genetic predispositions. We've had some research about some polymorphisms that affect the population susceptibility to influenza. We don't have any evidence so far about the current ongoing outbreak. Again, we're still in the early phase, but also we have to look at the behavioral factors in these populations. So I lived in the US, and the Black community, for example, has a different style of life. The families are more close to each other. There's more poverty among the Black community, and they live in more crowded places and community centers. So all of these factors could also contribute to the higher burden, the obesity among some of these populations, the delay in going to the healthcare for example. So we can't just only associate it with genetic variations,
That's fine.
while this could be a potential cause, but there are many other behavioral factors.
Okay, thank you. Other questions? Dr. Diala, Dr. Aad, do you have any comments or questions to add? Fine.
Thank you. It was very clear. I think Dr. Aad left.
Okay, so I'd like to thank you all for listening and participating. Thank you for the questions. The recorded version will be available on the YouTube channel under my name. And definitely special thanks to Dr. Zaraket. It was our pleasure hosting you. Thank you for your time, and definitely your intervention enriched our discussion.
Thanks a lot
And
for having
thank
me.
you. Hope we meet you in person after the Corona barrier. And also a special thanks to the Communications Office for opening the webinar to the public. Thank you, Tina. It was a great presentation. Thank you for all your efforts.
Thank you.
And you were quite courageous to keep the presentation open. And I wish all the students a smooth summer period. Stay safe, and hopefully we stay connected. Fine. Thank you all. And bye for now.
Thank you all. Stay safe. Bye.
Thank you, Dr. Hassan. Thank you. Bye.